Okay, so officially welcome to our June webinar. For those of you who are here for the first time, my name is Dr. Vladimir Miletic, and this evening or this afternoon, depending on where you are, I will be talking about pharmacotherapy for trichotillomania. The title of the webinar is Pharmacotherapy versus Psychotherapy. And this is, I guess, true to an extent because I will compare research, uh, but my emphasis will be on different drug treatments because last month, this is the topic that you've selected. I compiled the list of topics that you proposed for your poll for this month. So make sure to vote. And then when I'm done with the first part of the webinar, before we get to the Q&A, I will close the poll so that those of you that have to leave know what we will be talking about in July. This evening's webinar is not going to be terribly long, and this is not because I suddenly lost the desire to talk. As you know, I can talk forever. It's because there's really not an overwhelming amount of research out there. As I go through all the slides, ask anything that might not be clear to you in the Q&A, use the Q&A button. And then when we get to the Q&A portion, I will answer all your questions. The same goes for questions that may not be related to the subject matter, but you may be curious about. So this is what we will be talking about this evening. So first, I will give you a general overview in one slide. And then we will expand in more details about specific types of medication or groups of medication that have been either tested in small studies or that we may have case reports that indicate that they might be worth trying out. And then we'll talk about supplements, or rather just one supplement, which is NAC. And then we will briefly compare psychotherapy to all these medical options and see what would be a general recommendation in terms of how to proceed and which kind of treatments to use. And then afterwards, we will go to the Q&A, as always. So let me just give you the general picture. The situation is really rather simple. The bottom line is that we have no drugs that were approved by the FDA for trichotillomania. So strictly for hair pulling, there's nothing out there. There is research that's available to us, and there are medications that are being prescribed for hair pulling, although we don't have nearly as many studies as we would need to be able to formulate clear treatment guidelines. Overall, when we summarize the results, psychotherapy appears to be more effective than medication alone. So when we compare the two, psychotherapy tends to produce better results. In general overview, I can't spell, as you can see. So approaching treatment from different angles might be the best way to go for most people. I will elaborate on this more when we get to the end of the webinar. This was one of my New Year's resolutions. Sorry, I cannot resist a digression, which was not to use spell check so that I don't become illiterate, because I've noticed that I started relying on it too much, and then I go and misspell approach. This is just lovely. Okay, so let's sort of review different types of medication that we've either tested or clinically know that they might work. The first category are SSRIs, or selective serotonin reuptake inhibitors. It's a bit of a mouthful, but they are the most commonly prescribed meds for hair pulling for both adults and pediatric patients. However, I have to emphasize one thing here, which is that for children, so for pediatric patients, the choice of treatment is always initially, like the first choice of treatment is psychotherapy, because it has no side effects and we know that it is effective for sure. So this would be the go-to treatment. But when we look at all the medication that is prescribed for children and young adults as well, then SSRIs come on top. So what's the logic behind this? Uh, Trichotillomania seems to be very similar to OCD. And in the latest classification in the DSM-5, it is classified as basically, OCD adjacent, a part of the spectrum. So they are different entities, but they do share some things in common. They also have quite a number of differences, but because of the similarities that they have, it was assumed that maybe what works for OCD will work for hair pulling as well. So it's not particularly profound way of thinking, but it is something. And there have been a number of studies testing different types of SSRIs, and the results seem to vary. So certain studies will show that SSRIs are effective. Others will say they are to an extent, but not significantly so, whereas some studies have shown them not to be effective at all. So in that sense, results seem to be all over the place. They are commonly prescribed, and clinically, I guess, my sample are my clients. And when someone comes to therapy, typically everything they've tried before didn't work. So I guess, speaking from my experience, I can say that clients have benefited to an extent, but no, I'm yet to see someone who stopped pulling their hair because of an SSRI. Studies, as I said, are all over the place. What we know is that some work better than others. So fluoxetine, which is Prozac, um, seems to be less effective than other drugs that have been tested from this group. In case you don't know, the way that these drugs work is that they, well, the name kind of says it itself, doesn't it? So quick lesson in neuroscience. So the way that neurons connect is through these sort of structures that are called synapses. Basically, a synapse is when two ends of neurons meet, and then they form a connection, and then there's this space between. When neurons communicate with each other, they will secrete a chemical on one end. This chemical gets into this space between them and attaches itself to the membrane of the other neuron, and then activates certain chemical pathways, right? And because typically what happens is that a lot more chemicals are excreted than are needed on the other side. So there's always something that stays in the crack between the two neurons. What happens then is that these get reabsorbed and then degraded or recycled in some way. SSRIs, like Prozac, will block this reuptake. So when serotonin gets into this space between two neurons, and it will not be reabsorbed later on because of the action of the drug. So it will stay there and have a stronger and more durable effect. So this is how they act. Overall, they potentiate the effect of serotonin. This is their basic mechanism. Certain newer types of SSRIs affect other transmitters as well, but this would be the basic mechanism that they all share together. So that would mean, I suppose, that to an extent, we can say that hair pulling probably has indirectly something to do with serotonin as well. Although we are far, far from having a clear idea about the biochemical changes that occur in our brains during hair pulling. So just to summarize the results before I just dive into biochemistry, which I like, but I guess not most of you don't. Um, Study results are all over the place, and regardless of this, they are the most commonly prescribed medication. If they don't help directly with hair pulling, they can actually help with other issues that might make hair pulling worse. For example, SSRIs are prescribed for depression, SSRIs are prescribed for generalized anxiety disorder, and they are prescribed for OCD, all of which can either co-occur with hair pulling or can make it more difficult to treat or can exacerbate it, like anxiety. Because if you remember our webinars where we talked about different psychological mechanisms and functions of hair pulling, one of the things that we talk about is that it is a way to avoid certain distressing experiences, anxiety being one of them. So in this case, even if it directly does not affect hair pulling, it can be beneficial overall. And I think one of the reasons why they're so commonly prescribed is because most physicians have a lot of experience with them, so they know what they can expect. They know that they're not terribly difficult to bear. They don't have any drastic side effects, at least not for most people. So they seem like good candidates to prescribe. I think this is at least my personal explanation as to why they're the most commonly prescribed, because as you will see, other types of medication seem to be more effective than SSRIs. Specifically, when I say what's more effective than SSRIs, is this one, clomipramine. It's also an antidepressant, and it belongs to a group of antidepressants called tricyclic antidepressants. And this name, which kind of sounds cool, is basically derived from their chemical structure. So they have three kind of rings in their. If you ever look at the formula, you will see that they have these three rings and then all kinds of stuff attached to it. So that's where the name comes from. Clomipramine has been used for quite a long time in psychiatry. It was, if I remember well, and my pharmacology was a while ago, so I might be mistaken, is somewhere since the 60s this has been used. Nowadays, it's not prescribed very frequently. It is prescribed sometimes for very difficult and complicated cases of depression, but other than that, there are very few indications to prescribe it. Um, the reason for this is that it has quite unfavorable, side effects, and also it tends to be quite poisonous, so it can be even fatal. It's cardiotoxic, which means that in certain instances it can damage the heart. It can cause different types of arrhythmias, something called the QT, interval prolongation, and another even more dangerous one, which I will not pronounce because my French is embarrassing and it is a French name. So it can be quite toxic. The way that they work, in a sense, is similar to SSRIs, in the sense that they also have an effect that they kind of potentiate the effects of serotonin, but they're much less, they're much more indiscriminate, I guess would be a way to say. So clomipramine, for example, will antagonize certain receptors of serotonin. It will act on certain adrenergic receptors, and also it will inhibit calcium channels and sodium channels, which is why it has an effect on our heart. So because it has all these chemical effects, it basically does too many things for us to keep track of. So they're not that easy to dose, and side effects are not that easy to control. So this is why they're not commonly prescribed these days. And although they seem to be, this drug in particular, clomipramine, seems to be more effective for hair pulling than SSRIs. Again, the number of studies is not huge, so we're talking about studies in single digits. So the evidence base is not overwhelmingly strong, but what we have seems to show that it is more consistently efficient than any of the SSRIs that we have. And then there are other types of medication that have been tested or reported to be effective. Namely, some of them come from the group of antipsychotic medications. And in fact, I've found either case reports or small studies that show that three of them are effective, and I've listed them here. So I guess aripiprazole, it's the name under which maybe you know the medication is Abilify. So it's one of the most commonly prescribed antipsychotics. I believe it's actually one of the most prescribed medications in like top 100 in the US. But the evidence base that I've seen is underwhelmingly small. So I found a small study that had so few participants that actually the statistics, I doubt, is terribly reliable. And I've seen a case report where a client stopped pulling with aripiprazole, Abilify. Let me just shorten that. And then olanzapine also seems to work. And the effectiveness, kind of like for this entire group of medications, has to do with its dopaminergic effects. Because speaking in most general terms, antipsychotic medications affect this system of neurotransmitters specifically. So olanzapine, the trouble with it is that it has a lot of side effects, such as weight gain, for example. Abilify also tends to have unusual side effects, including hypersexuality and even, I think, proneness to gambling. So it has kind of strange side effects. So even though there is a little bit of evidence that they work, so literally just several small studies and mostly case reports, what I was able to find, when I say what I was able to find, meaning in peer-reviewed journals, so that's where I'm looking for. I don't think any reasonable psychiatrist would prescribe this as a first line of treatment. However, the case reports that we have and the studies that I've seen at least give us something to go on. So uh, I guess the most that we can say about this group of medication is um, that they merit more research. But I don't think there's more to it than that at this point. Because a case report is more like a scientific curiosity. It should spark more structured research, double blind, placebo studies, like something that actually has statistical merit. And then we have mood stabilizers. They also have an effect. And I found a study, I believe, by a group of Polish authors, and they looked at what happens with hair pulling in their patients who also have bipolar disorder. And apparently, certain mood stabilizers, such as lithium, um, have a beneficial effect. And I believe that they even use the words stopped pulling. But just keep in mind that, again, all of these medications are very difficult to sort of introduce. They're difficult to taper off. They all have side effects that are not always easy to tolerate. And lithium specifically is highly toxic. So I doubt that this is going to become a recommended form of treatment anytime soon. However, what is interesting, what I was able to find in several studies, is that the proposed mechanism of action is through hormonal effects of mood stabilizers. And the reason why I say this is because I've noticed working with clients, one of the arguments that they make is that most patients who struggle with hair pulling happen to be women. And there is a study that I found that lithium can sometimes modulate, or rather alter, the way that certain hormones like estrogen are secreted. So there's something there, although it's hard for me to say precisely what. In general, the way that lithium affects and stabilizes the mood hasn't been well researched. Like there are several hypotheses that I've read about, but none of them are kind of, to my knowledge at least at this point, conclusively shown to be true. So even this proposed mechanism, I would take with a grain of salt. But where I see certain, let's say, clinical equivalent, is that clients will often report that pulling will vary according to their cycle, for example. So there will be, time periods in the month where female clients would be more likely to experience more intense urges or more pulling, or then also, I guess, less pulling in certain other side parts. So for me, this is important in therapeutic sense because it allows us to be proactive and plan strategies accordingly. This is not always the case, but I have noticed this, and it seems to be quite frequent. So perhaps there is something to that as well. So these would all be the psychiatric medication that I've found studies and data on. Now we have NAC, which is a popular supplement, that, again, there isn't an overwhelming evidence base that it works, but there are studies that show that it does work. One study said that there was a 50%, 56% improvement compared to placebo. In this study, about half of the people experienced improvement, and that improvement was about 50%. So basically, half of the people who take it will reduce their urges by and pulling by one half. That would be a rough way to look at it. The dosages that I've seen ranged from 1,200 milligrams per day all the way to 24. And treatment length varies, but it is about 12 weeks, more or less. So the way that NAC works isn't quite clear to us. It modulates certain neurotransmitters, and also it has antioxidant and anti-inflammatory effects. So one of these is probably why it works. It is a supplement that's used for other reasons as well. So some physicians will recommend it for bronchitis, for example. It's used as an antidote in certain cases of poisoning. So it has a wide variety of uses in medicine. In general, it's well tolerated. So it is safe to try. And this is possibly the only thing that I have mentioned today that doesn't require a prescription from your physician. So it's something that's relatively harmless. Sometimes it can cause an upset stomach. So if you're going to do it, try to sort of slowly increase the dosage. Don't just take a big one immediately. And again, compliance is necessary. But 12 weeks is something that is a period of time where it's reasonable for you to wait and to see if you experience any results. And also, if you do, I would really like to hear from you about your experiences, because from clients, I can hear that I hear stories that are really vary and they're all over the place. So some clients have experienced certain benefits from it. Some have even said that it was really good in terms of reducing those intense urges, but some have experienced absolutely no change whatsoever. So I've never done any systematic research on the subject, but just listening to my clients' stories, it's kind of difficult to say who it will work for and who it won't work for. So I would like to hear your experiences. You can even type them here if you have some. It would be interesting to hear why you think it worked and sort of what your pooling was like, so that we can maybe draw some conclusions. And so now on to comparisons with psychotherapy. So when we compare psychotherapy versus SSRIs, so Prozac and similar medications, Zoloft as well, SSRIs have a moderate effect, whereas psychotherapy, behavioral psychotherapy specifically in the study that I got this from, seems to be more effective. And in fact, the longer one goes to psychotherapy, the greater the effect. This is something that I can also confirm from our side, sort of from TrickStop. That when we take a look at how long our clients stay in the program, the longer they stay, the more they tend to benefit. So this is also something that I can say from our data to be true as well. When we compare clomipramine versus psychotherapy, it seems that clomipramine is statistically insignificant compared to the effect that psychotherapy creates. So it's better than SSRIs, but still far inferior to psychotherapy. Overall, when we form these recommendations, clearly the research that we have is really not enough. You know, case reports are all nice and lovely, but no one can generalize on an entire population based on a case report. Small studies, again, good starting points. None of them actually give us anything conclusive. So when we form treatment recommendations, we tend to look at it from a pragmatic point of view. If you can attack the problem from both sides, it's probably more beneficial. We know, for example, from certain studies on treatment of depression, is that when you combine medication and psychotherapy, you seem to get a kind of synergistic effect. So you get more than you would get from using individually only one. So I guess it's reasonable to say in this case as well that if you have the ability to combine the two, that is probably beneficial or more beneficial than using either one. But if you have to choose a form of treatment, psychotherapy tends to work much better. And this goes for all BFRBs. So I'm speaking here specifically, the data that I was showing here up until this point is related to hair pulling specifically, but psychotherapy appears to be more effective for all kinds of BFRBs. So for hair pulling and nail biting and all the similar problems. There are different types of psychotherapy that have been tested and tried out. Uh, Different types of therapy also seem to work, so there is no preference for one specifically. Some that work well are habit reversal training, which we incorporate in our program as well. Then acceptance and commitment therapy, also something that we incorporate. And other types of CBT have also been tested. So we have reasonable amount of evidence for different types of therapy. So it's not like you have to find one strict and specific form of psychotherapy. I think when choosing a therapist, it's perhaps more important to find a clinician who knows what hair pulling is and how to treat it, rather than the specific type of therapy they seem to be engaged in. I guess what you should be mindful of is that different types of therapy will have different ways of working, and then also results will come in different forms at a different pace. So when you assess it personally for yourself, it is important to kind of know how to set these expectations. So that is beyond the topic of what we're supposed to be talking about tonight. But if you'd like to hear about different forms of therapy, how they work, what the basic ideas behind them are, this is something that we can talk about in some of the future webinars. And the image on the left is my subtle propaganda for TrickStop, because this is the sign you've been looking for. So the studies also indicate that therapy, although not necessarily TrickStop, obviously, is perhaps a better way to go. So that's everything I have prepared for you today. I think this was maybe the shortest webinar that I've had so far, and I'm proud to say that I managed to say everything I had in under 30 minutes. Which for those of you who are here for the first time may not be a big deal, but those of you that know how long I can go on and on for, this is for me almost miraculous. So before we proceed to the Q&A, I would like to thank TrickStop for allowing us to meet as they do every month. For those of you that might be interested in trying out the program, take a look at the coupon that we have that will give you the discount for the first month. Or tune in next week because we have that short promotional webinar where I will tell you more about how TrickStop works, in case you want to learn more about it. Now let's stop the polling and see what is it that we will be talking about in July. So the topic that won, and quite handily so, I have to say, is mindfulness of the body and hair pulling. So I guess